Next up, we have another lightning session, so 15 minutes in total, and this will be on a study that's been done on NHS Theatre Tariffs for lower limb surgery and the case for reforming that to reflect its complexity. This will be presented by Kanan from the Royal Free Hospital NHS Foundation Trust. I'll now hand you over to her for the presentation.
Hello, so my name's Janan. It's just a bit difficult. I think my colleagues are just sharing the screen for me. So if we go on to the next slide. So we'll be discussing a question today, the NHS Theatre Tariffs for lower limb surgery. Is it an unbalanced system? So before looking at the financial data, it's useful to understand how the NHS funding works for surgery. So first, there's the national tariff, the NHS price list for procedures. Hospitals receive a fixed payment for each operation. So a knee replacement is paid the same amount regardless of the patient's length of stay, their complexity or implant cost. It's designed to standardise costs and encourage efficiency. And then secondly, there's block contracts. So instead of paying per case, commissioners give the hospital a set annual sum to cover an expected volume of activity. It gives both sides predictable budgets, but it can create problems if the actual workload doesn't match what was planned. And as we'll show, it becomes much less balanced in complex lower limb surgery, where the real cost often exceeds the fixed tariff that the hospital receives. And if we go on to the next slide, it shows us, it brings us to the heart of the problem. Are tariffs fit for complex patients? And the short answer is often no, but let's have a look at the elective hubs and main sites. So the main sites there's a risk to the main sites because the tariffs are fixed. The main hospital sites, which take on the most complex and high risk cases, are consistently underpaid. And you can see that the system encourages a split in service delivery. So if we have a look at the elective hubs and main sites, we can see that the elective hubs focus on the high volume, low complexity cases. They avoid the costly unplanned admissions, achieve a faster turnover and maximise on tariff returns. And the main sites are left with the high risk complex cases. They have the intensive care units and can manage any complications that occur, but their slower throughput means that they lose money under the fixed tariff model. And if we go on to the next slide, it shows that this our aim for the project. So given the financial pressures we've just outlined, our study set to answer two key questions. The first one was to evaluate the cost versus incomes at a lower limb surgical list at a main hospital site and identify each factor contributing to costs. And if we go on to the next slide again, and to answer these questions, we conducted a focused real-time analysis and data was collected over a 6-week period and it included 13 lower limb lists, which span hips, knees, foot and ankle cases, giving us a representative snapshot of a typical workload at a main hospital site. And our costings and income data were provided directly by the finance team. Now, if we go into what the results show us, and it tells a clear story. I mean, you can see from the figures on the screen that the income we received was 266k, and our cost was significantly higher at 366k. So it left us with a net substantial loss of nearly £100,000. And if we have a look at the breakdown, we can see that the knees were highest in volume with 28 procedures, but lost over £51,000, averaging a loss of about 1.8k per case. And then our hip cases although they were fewer at only 7, they incurred the steepest per case loss, just about 5.7k each, totaling a loss of about £40,000. And foot and ankle surgery performed only slightly better, but it still lost money averaging around £855 per case. And if we have a look at the next slide, so if we have a look at the knee cases, we can see that nearly 90% of all of the costs came from just over 3 areas. So the theatre staff, theatre non-pay, which are things like swabs, and I'll talk about this more later on in the presentation, and ward costs, which alone accounted for about £202,000. Implants and loan kits together came to about £20,000. And this data shows us that the real financial pressure isn't just about the expensive implants and screws, it's about how we use our time, people and beds. And if we go on to the next slide, the theatre time is our most expensive resource. It costs just over £1,300 per hour in theatre staff alone, and that's before electricity, equipment and overheads. So in a 10.5-hour workday, every idle hour costs us £1,300, and the real loss is even higher once all of those overheads are included. So here's the point that I'm trying to get across. These costs are mostly fixed, so adding one case barely increases the expenditure, but it brings in a full extra tariff. So the small cost increases can produce a large profit boost when we use the theatre time fully. So if I just put it simply, we're already paid the theatre time. Whether we use it or waste it, the cost still remains the same. But if we add just one more procedure in, we turn a loss-making session toward profitability. And if we have a look at the next slide, which is the HIP data, our HIP data set, we can see again that our largest expenditure is in our theatre staff, which come at around £36,000, which reinforces what we saw earlier. People and time are our biggest cost drivers. Next, ward costs account for about 20% of our total expenditure, highlighting the impact of longer inpatient stays, which are often required for these complex hip patients. Now, if we go on to the next slide, we can compare this with knee surgery. We can see that two main differences stand out. The implants account for a much larger, bigger cost, a bigger share in cost. So it's 10.2% in hips compared to only 5.8% that we spend in knees. And hip cases are often more complex. They lead to longer inpatient stays and higher resource use. So where can we reduce our losses? So theatre time, that's around nearly half of the cost. And we can do things like improve list planning and reduce gaps. Number two are things like ward costs, which we can do by shortening post-op stays, by virtual wards, by enhanced recovery pathways and proactive discharge planning. And implants, which are 10.2% of our total costs in hips. It's not the biggest cost slice in this, but it's still substantial. So what we don't need to focus on here is things like drugs, imaging, pathology, and other small categories. They're under 5% of combined of our total cost. So in summary, to make hips surgery financially sustainable, we need to do things like target ward flow, theatre efficiency, and implant management, not the low impact areas. And if we go on to the next slide, we can see the foot and ankle cases. Theatre staff is still our biggest expense at just over £19,000, but note it's significantly lower than the other the surgeries, partly because these lists often run more efficiently with a faster turnover. So it's significantly lower. And implants only cost £379 across all foot and ankle cases in our study. And that's less than 1.5% of total cost compared to just over 10% in hip surgery. And if we go on to the next slide, we can compare foot and ankle surgery to hip and knee procedures. Three main differences emerge. So the first one is that the implant costs are drastically lower. Secondly, there's no inpatient stay. So every foot and ankle case that we had in our study was performed as a day procedure. This alone removes one of the largest variable costs that we see in the hip and the knee pathways. And thirdly, more cases per list drives down theatre costs. So because the procedures are shorter and recovery is quicker, we can safely schedule more operations in the same theatre session. So what does this mean for the bigger picture? It shows that foot and ankle surgery operates on a leaner, more financially sustainable model. It reinforces that when we remove these inpatient stays and control the implant spend and maximise theatre throughput, lower limb surgery can move towards financial sustainability. And if we go on to the next slide, theatre non-pay is an important category. These are things outside of our staff and implants and things like swabs and disposable equipment. Our data shows that whilst these costs are real, they're not where the big savings will be found because these items are essential and non-negotiable. So if you need a specific swab or a certain drape for a procedure, you need it. There's little room for substitution here without affecting patient safety. So whilst we should always be mindful of waste, replacing these items is unlikely to change the financial data set significantly. So if we go on to the next slide, let's bring this into a real world example. So here was an actual theatre day from our data. We can see that only 2 cases happened. So it was a total hip replacement in an ACL reconstruction. And a third planned list, third case was cancelled. So you can have a look. Our net was minus 21k, which is quite substantial. And it shows that once there's a cancelled case, the fixed theatre costs are spread over fewer procedures. So it drives up the cost per case. So let's imagine we add 2 knee arthroscopies to the cancelled slot. And if we go on to the next slide. So adding 2 knee arthroscopies, you can see that the total net income would be 4,500 times by 2. So it would be a new income would be 9.9k and our new total cost would be only 9k. And if we go on to the next slide, we can show you some figures. And we can see that the new net profit from these additions would be £922. And this cost would be even lower because I've taken it from another day. but we'd still be at a loss. If we go into the next slide, I'll show you. So it will be, so our new net profit is £922, but if we take that from the total loss of minus 21k, we'd still be in a loss of minus 20k. So even with 4 cases, how is this possible? So it shows that the core problem is that the NHS tariffs, which don't match the real local costs, we're paid a national average, but our staffing and implant costs are much higher. So high cost procedures often run at a loss. And things like low cost procedures like arthroscopies, as you see on the previous slides, and like metalwork removal, they bring in too little income to cover their share of the fixed theatre costs. And again, complexity isn't reimbursed fully. The tariff assumes a national a standard patient, which doesn't account for the extra time, the senior input, and longer stays that often these complex patients they need. So doing more cases only helps if the cases themselves are profitable, and currently too many aren't. And if we go on to the next slide, so we proposed 5 recommendations here. Our first one would be to increase the cases per day. So if we add short, efficient cases to underused lists, we can boost revenue without increasing our staffing costs too much. And we prioritise on efficiency. So on-time starts, that's smooth preparation and minimal turnaround time. And then we can, another recommendation is implement enhanced recovery pathways. So early mobilization after these complex surgeries and an optimized analgesia regime. When we do this, we try to reduce the length of stay, especially for these hip and knee procedures. So by doing this, we can cut ward costs and improve flow. And then again, improve on discharge planning. So if we identify these social and clinical barriers preoperatively and use an MDT-led discharge from day one, this reduces our ward cost per day, which is quite significant as well. And number 4 would be to secure fair tariff agreements. So if we can advocate for tariffs that reflect true local cost, especially for these high complex cases and these high implant costing cases, and this is essential for long-term viability. And then we can benchmark against elective hub theatres. So we can review high-performing hubs to identify any transferable models that can be used in these main hospital sites, things like scheduling strategies and case mix efficiencies. So these targeted actions hopefully will help safeguard our services, our staff and patients in a challenging financial climate. And that is my presentation done. Does anyone have any questions?
Thank you very much for that. That was a really interesting piece of work with some hard-hitting results and messages as well. We've got a couple of minutes left for a bit of a Q&A segment. I suppose a question from me actually. What were some of the main challenges you faced when doing the piece of work?
Like collecting the data?
Yeah.
Actually, our hospital income and costing department were very good. They came forward and they gave us lots of good data. But I think the most shocking thing for us was like the amount of loss that we incurred per case and per day. It was still quite significant, even when we had a full theatre day. I mean, you saw by the example that I gave, we'd still be in quite a big loss, and that was quite shocking to see how much the NHS would be losing with these unfair like tariffs and the unfair payments. I guess that was just quite shocking and interesting to see actually.
Yeah. It is. And you've made some recommendations there. Have you got any plans to take those forward at all?
I think the most important thing for us was you saw in our data set, our hips lost around had the highest per case loss of about 5.7k, and although theatre costs were quite a significant factor in that, it's also the ward costs. So the patients that didn't need to stay as long as they should have done. So what we can learn from this is improve discharge planning. So getting all of the wider MDT involved in the patient's discharge and planning things like getting things like occupational therapists to go into their homes and arranging everything that the patient needs at home so they don't need to stay in hospital. That would significantly reduce the cost that these patients cause the NHS. I know and making it safer for them to go home makes it cheaper for us and better for the patient as well, reduces things like post-op infections.
Okay, that's been brilliant. Thank you very much. We're now at time, so thanks for joining us. That's been really interesting. We now head straight into our next presentation, but please just give us a few moments while we transition to our next speaker.